So let's make a start. So tēnā koutou katoa. Welcome to tonight's webinar that Ruth Barratt has kindly joined us from Sydney, Australia to present on infection prevention and control measures. Ruth is a registered nurse, quality advisor and researcher with a master's in infection prevention and control. She has over 20 years experience in this field, and tonight's focus will be around COVID-19 and the PPE. It is clear how relevant this is in the current climate and reflects the 780 plus registrations for tonight's webinar. During the presentation, please feel free to use the question and answer function to ask your questions, which there will be time to be answered at the end of the presentation. You can also use the chat function to introduce where you are from. So without further delay, I will pass you over to Ruth. Thank you.
Thanks, Catherine, and thank you everyone for joining. There's such an interest in this, which I can totally understand as an infection prevention control practitioner. Although I'm in Sydney currently, my heart is in New Zealand. I am a New Zealander now, and I've worked in infection prevention control in New Zealand for over 20 years. I'm currently actually in Sydney doing my PhD, and that's into protective masks, which is very ironic considering that is such a topic at the moment. So just a disclaimer really before I start. I don't have any conflicts of interest to say, and I also just want to say that although I am working in Sydney, I'm not talking from an authoritative voice within Australia management of COVID, and neither am I talking with an authoritative voice from a Ministry of Health New Zealand perspective. What I bring to tonight's webinar is my expertise in this field and my practical, if you like, experiences now working within a busy tertiary hospital, which is the Biopreparedness Containment Centre for New South Wales, which is Westmead Hospital. And I've recently had an appointment as a clinical nurse consultant for that particular area. It just happened to coincide with COVID. It was not made for that. So there's been a baptism of fire into that particular role, and I'll just bring some of those experiences to tonight's presentation. What I want to start off with, though, is a little limerick, and some of my friends who may be listening know that to try and keep myself sane within the PhD work, I have created a few limericks. And this is one I created before the COVID. So there was an infectious disease which brought the whole world to its knees. When they sneezed and they coughed, we donned and we doffed and survived with barely a sneeze. So that was really all about managing to use our PPE correctly, and that will keep us safe. And while we know that sneezing is not a particularly common symptom at the moment with COVID, it just highlights what we should know. So that's just a little bit of lightheartedness to start the evening off. It's 5 o'clock here in Sydney, and we've had a wet day, and now the sun's shining because all the Kiwis are joining us. So that's great. So once again, your point of truth for anything to do with COVID-19, the novel coronavirus, is your New Zealand Ministry of Health website. Now, whether you agree with what they put up there or not, that is, those guidelines have been developed by experts in their field. They are also guided by public health surveillance and other surveillance that's going on. So you should all know how to get to that website, and that is full of some very useful resources. And I have been on, obviously going to do this presentation, and had a look, and every single day it is updating. So on the 30th of March, they put up all these posters, etc. for PPE. And I've got to say, I was just talking to Catherine earlier, I really like the icons, and I am quite like the posters that have been developed. But there is my area that I'm talking about tonight is, of course, about personal protective equipment. And there is a whole section there that's called What's Important for You to Know About PPE. And they list quite a few different areas of speciality. So, for example, midwives, long-term age residential care, GPs, that sort of thing. Now, I don't profess to know every single word that is in the New Zealand Ministry of Health guidelines. And if some of you ask very specific questions around that, I will probably not be able to answer, and I will direct you to this source of truth. I have sat on some of these guidelines in the past when I've been within Infection Prevention Control New Zealand, but obviously not currently. And I do know that we do our best to get the truth, as it were, out there, but you can't please all of the people all of the time. So just realize that these are based on the knowledge that we have as of today, and this has been such a fast changing scenario within the space of infection prevention control, PPE, public health, case definitions. It's really exhausting trying to keep up with even the evidence that's coming out. On the other hand, China, who has done so well, is publishing lots and lots about their case management. So anyone that's interested in the clinical case management of some of the patients and how they presented and the different ways they presented, I would urge you to start, maybe having an alert for, publications that come out in your area of interest. So within the New Zealand side, as I said, within the PPE side, there are tables and there's lots of posters, and posters for different types on roles of staff. So on the left, we have one that is developed for staff caring for COVID-19 positive patients in hospital. And I think they're quite well set out. And so, for example, I've just highlighted one of the examples where they say that the indications for using a surgical mask. So if it's a single room, you use it for all patient interactions, whereas if it's a cohorted room, so that means a bay or two or more people, you can keep it on until the mask becomes damp. So you change it as per your PPE doffing guidance. Now, there's no point in me telling you that we have a worldwide shortage of PPE. There is a lot of problems in every country in the world trying to access PPE, and I'm going to talk about that a little bit more detail. So we have gone to more extended use, if you call it, of PPE, and this is an example of that, whereby you might go into a room, you'd be taking observations, say, on 4 people. So between those 4 people, you change your gown and gloves and clean your hands as per the 5 moments for hand hygiene. But you can keep your mask on, and certainly where we work, we keep our eye protection on. Because at the end of the day, you are not touching those patients with your mask or with your eye protection. However, if you then, between 2 patients, say, go and adjust your eye protection, or you adjust your mask and you touch the outside of it, and then you go and touch your patient, or you touch their space, you have then cross-infected that COVID. So when we're using this extended use of PPE, we have to be very, very mindful of what we're doing with our hands. And we cannot stress enough about how we manage wearing PPE. And that is the big thing to do to keep yourself safe throughout this COVID outbreak and pandemic. So the other one I just wanted to highlight is this one, which is for people who do not have COVID. So this is for aged residential care and age-related community care. And it just shows you that in those community settings, if you're looking after people who do not have COVID and who are not in isolation, then we have to be mindful of our standard precautions. So we don't need to be wearing masks routinely. We don't need to be wearing P2 masks. We don't need to be wearing eye protection. We need to go back to our standard precautions. And the World Health Organization has made that very clear this week, that we have to be pushing what our standard precautions are and remind people what they are. And this has been a very interesting outbreak from an IPC perspective. And I know my colleagues out there and many of you will become acutely aware that suddenly there's a whole raft of healthcare workers who are starting to understand exactly what standard precautions are. Never mind what droplet precautions are, they're suddenly realizing, oh, maybe I should have been, protecting my face doing that procedure or other things. So the basis of a lot of this is, first of all, standard precautions, and then we build on that with our droplet and our contact precautions. So this is just an example of some of the posters, and it reflects the guidance that's out there. And the guidance that New Zealand has put out is very much in line with the national Australian guidelines. So we're bound we work very much state by state as well, but there is an overarching body who provide at national level guidance for infection prevention control, and I sit on that committee as well. And there's not much that I've seen come out of New Zealand that isn't similar, that we're not doing similarly. So Australasia always has been pretty similar, and it seems to be so for COVID. And certainly our colleges are often shared colleges, so our intensivists, our ANZICs guidelines are shared guidelines, for example. So I'm just going to go back to basics to just remind us what we're doing. So I'm not going to apologize for the basics. I think there's so many people have had to be told about basics in this COVID, but we are trying to break the chain of infection. So we all know about our chain of infection with our infectious agent, etc. And we want to interrupt that transmission. So if we go to breaking the chain for COVID-19, our infectious agent, at the moment, there is nothing that we can kill it with. Certainly, we have not got any, treatment that we can give that will definitely kill it. There are adjunct treatments that have been tried in other countries that may or may not be beneficial, but we've got no definitive treatment that we can say, this is how we will kill this COVID-19 in this patient. Of course, our reservoir is our people and the environment. So how do we break that transmission? Well, we know we do social distancing, and we all know about that. We've got respiratory hygiene. We can't stress that enough. Hand hygiene, of course, and our environmental cleaning. So the portal of exit is our respiratory droplets and our hands for contact. So if we think of our droplet and contact as the spread, we want to do our respiratory hygiene and cough etiquette. We want to perform our hand hygiene as appropriate. And we may want to wear a surgical mask or put on patients a surgical mask in appropriate situations. We may ask them to wear a mask to prevent them from spreading their droplets. Our mode of transmission is primarily droplet and contact. And airborne only comes into play when we start aerosolizing those COVID or coronavirus droplets. So how do we do that? Again, we introduce standard precautions, and we add on then our transmission-based precautions of droplet and contact. And sometimes when we have airborne, we might want to make sure that we have some sort of air handling control. And where we can, we will try and isolate these patients. So air handling engineering control is ideally for airborne. We're talking about negative pressure rooms, but we're also talking about closing doors, not putting people in positive pressure areas, which is interesting. You may be in a hospital and think that everything's covered off, all your negative pressure rooms. We had a bit of a shock. We thought we had a bunch of negative pressure rooms where they were actually tested, even though they had been tested previous this year. We found that there was quite a lot were sort of positive. So you may want to get your engineers to check that. Of course, if you don't have engineers handy, you can close the door and go along with your tissue paper and see, does it fly under the door or is it pushed away from the door? So it's just important, if you don't have negative pressure rooms, that if you have someone in isolation, that they're definitely not in a positive pressure. In other words, they're not, when they're coughing, that is not flying out the door, under the door, around the door, into a shared corridor. Our portal of entry to ourselves and to others is definitely respirators, our mucous membranes. So some of that is around safe infection prevention and control practices, using our PPE correctly and safely, which I will talk about a little bit more, and hand hygiene. So it's not just about PPE. You can do things like when you're taking a swab, you can turn your head slightly. You can make sure that you're not in the, in the direct force of someone coughing into your face. This is especially true with children and that sort of thing. And just have things like barriers up. So, there's a lot of perspex barriers being put up now on counters and things. And some of us already had those in EDs and places, but those are the sorts of things that you can prevent that direct portal of entry directly into your nose, into your mouth, and into your eyes. And of course, the susceptible host, wouldn't it be lovely if we had a vaccine already or some sort of prophylaxis? But we don't. So if we're going to break the chain, we have to try and work on those measures on the right-hand side and coming round to preventing the portal of entry. So that's just a basic reminder of what, we do with the chain of infection. And I just want to talk a little bit now about the transmission routes. So the original so first of all, they're still not fully understood, saying that China started in December, we're now 3 months down the line, and there is more and more understanding as more cases. But like any novel infectious disease and emerging infectious disease, there's still a lot more to be understood. We know that it is originally came from live animals to humans, and spread that way, and then very quickly became a human-to-human or person-to-person spread. I'm not going to go into all the theories of which live animals may have been the host and which may have been the intermediary, but it's pretty certain that was the original source. And with the person-to-person spread, it's respiratory droplets, and it does resemble the spread of influenza to a certain extent. The virus is contained in respiratory secretions, and that happens when a person coughs, not so much sneezing with COVID or talking, but many people have a dry cough with COVID, and some of them have a more productive cough. So we are talking about respiratory secretions. I will talk, I'll just mention about fecal-oral route a little bit later. So the infection occurs with, you've got direct contact with mucous membranes with your hands which are contaminated, or somebody coughing into your face and you're breathing it in, or they cough and it goes in through your eyes or your nose. Or you're touching those mucous membranes, having touched a contaminated surface that has a live virus on it. And I don't know how many times we have promoted this, do not touch your eyes, nose or mouth, and that is a big thing now. And it really takes a lot of sort of changing behavior sometimes not to scratch your eyes or nose, and we can all probably relate to this. You see, well, I certainly see, I do public transport, I see people in supermarket on buses, they will often wear gloves, and it's quite interesting because gloves may, in that sort of public arena, deter people from touching their eyes, nose or mouth. But I've also sat and watched them touch everything else and then still go and touch their eyes. So I've got very mixed opinion about wearing gloves in the public sort of community sector. However, I have noticed that some places are suggesting that might be something for the general public to do if they want to wear gloves. So I see a lot of gardening gloves out there and that sort of thing, which is quite interesting. And then the transmission route of airborne is still only during aerosol generating procedures. So those aerosol generating procedures I have listed in another slide, a later slide. So there was a recent study that looked at 75,000 cases of positive COVID in China, and there was no evidence that any of it was spread as airborne. Last week there was a paper came out which suggested it was airborne, and there was a lot of angst and a lot of social media went on about that. If you actually looked at it, it was an artificial situation of close to like having similar to having a nebulizer in a room. So it wasn't real life, and I still, and many of my colleagues still believe that airborne transmission does occur, but only when you create aerosols from droplets. So you make them so much smaller that they become more, they're traveling through the air much more than just falling quickly to the ground. The WHO, the World Health Organization, put out, this was the paper I was just referencing, so they put out a scientific brief a few days ago, and this was really to try and get on top of this misinformation that's out there. It's all about modes of transmission. And so they are saying that current evidence shows that it's primarily through respiratory droplets and contact routes. And they analysed over 75,000 cases, and within those, airborne transmission without aerosol generating procedures was not reported. And it is obviously possible if you do create aerosols, which are much smaller than droplets. There have been no reports of fecal oral transmission of the COVID virus to date. Now, we know that it has been found in fecal matter. There's no doubt about it. People have identified it in the laboratory in feces, but there's been no reports that it's actually been spread that way. However, it doesn't mean to say you wouldn't take precautions, continue your contact accordance with someone who may have diarrhea, and we certainly know that some of the cases do have gastrointestinal symptoms. So you would always manage that as you would any sort of loose bowels and diarrhea, and just take precautions under your contact precautions. There are varying rates of transmission. In other words, how many secondary cases do you get from one positive case? Now, if you've got a very high density area of transmission, such as Wuhan City was, you might get up to 5 secondary cases. Other places we've only seen 1. And what is coming out now from China is reporting that primarily secondary transmission occurs within households. So most of that secondary transmission occurs among people living in the same house or the same abode. It seems to be higher in the earlier stages, only as much as the viral RNA, so that part of the virus which is infectious appears to be higher soon after the symptom onset. But we're still early days in that sort of, evidence. So this whole thing about transmission from asymptomatic individuals is suddenly going to become a very worrying thing, as in I heard that China are now going to include in their numbers anyone that they have tested who didn't have symptoms. And we've certainly all heard of people who are positive who may not have symptoms. However, we do still not know whether there is ongoing transmission from those individuals. So they may have serology that's positive, but we don't know if they're actually transmitting it. There are certainly some cases where they have been, and there are cases that have been presented in the literature for that. But at this stage, without large-scale screening serology, looking for the antibodies, we don't know how many individuals who haven't been tested because they haven't got symptoms are actually positive, and how many necessarily have transmitted it or received it from an asymptomatic patient or individual. So this is often a worrying thing, and I'm sure that the evidence is likely to change, or at least the rhetoric around this is going to change over the next week. I can only talk to you what I've prepared for the last few days. So as I said before, the actual virus, which is SARS coronavirus 2, the RNA of it, has been detected in blood and stool specimens, but the China evidence suggests that it's not a significant factor for ongoing transmission in those feces. So with this little, some of you will have seen this. This just demonstrates how droplets actually go. So this is droplet transmission. So the whole point of, I'll just go back one more, is that we want to contain those droplets. And that's why a surgical mask will work, because you can see those droplets are already falling to the floor, excuse me. And so generally this is droplet transmission, and this was in 2014 this was filmed, and is a nice little clip to demonstrate that. Just so if we talk about airborne transmission, which we tend to want, so with airborne transmission and airborne precautions, that's when the P2 or the N95 particulate respirator mask comes into being, and this is often the biggest bone of contention among healthcare workers. Should they or should they not be using that level of mask? And certainly for the last 20 years, there's been a lot of literature which has debated whether it's safer to use a P2 mask versus a surgical mask for any of the emerging infectious diseases and or influenza in general. What we do know, because we can't really do controlled trials, is that when the evidence that has looked at this, the literature that's looked at it, has really not found strong evidence for P2 masks for SARS, say, or MERS, or outside of aerosol generating procedures. So I'm just going to explain what aerosol generating procedures are, because certainly everyone is advising that if you are looking after a suspected COVID patient or a confirmed, and you are doing any of these procedures, it can generate aerosols from the COVID droplets, and therefore you should have a tighter mask on, and preferably one that fits through a fit check, that filters out 95% of the virus, such as an N95 or P2 mask. What you'll notice there is that taking a nasopharyngeal or a throat swab does not constitute an aerosol generating procedure. Now, I'm sure there are some people out there would like to have a long debate with me about that. I'm not going to do that today. It's not considered an aerosol generating procedure by most guidelines throughout the world, and it's not by New Zealand, and it's not in Australia. So we're sticking with the party line on this, and a surgical mask, if someone coughs from taking a swab, that would be sufficient for this. There's a few things there that you might not think about if you are one of these people that happen to work in an intensive care unit. Turning the patient to the prone position can, if they're on a ventilator, could generate it's a risk, because they could become disconnected from the ventilator, and then the tubing with the force of the gases can actually cause aerosolization. Nebulizers, as we know, are a big no-no, and non-invasive ventilation should be discouraged at all costs. So non-invasive ventilation like BiPAP or CPAP is a difficult one, because we've certainly had patients whereby their first modality for treatment would be to put them on some NIV. We wouldn't want to intubate them, and yet we've gone ahead and intubated them because that is the safer option for the greater good. And so they've been intubated, and then they have recovered, but they would probably, in other circumstances, some of them may have managed to recover on BiPAP or CPAP. But it's such a high risk of spread of the disease, like nebulizers are, you just wouldn't do that in the first instance to try and minimize that. And there are, I don't know all the colleges' specific guidelines, but I do know that the ANZICs, or the intensivists, for example, and the anesthetic people, they have great guidelines in how to not get to that situation, or if you're getting into an intubation, how you can minimize the aerosols before you actually have to intubate, and just practical things you can do to prevent that aerosol generating, prevent as many try and prevent most aerosols happening. So the least number of aerosols. So there's practical stuff, at that level that are recommended. And all the specialty colleges have gone down that line and recommended practice things. So just to go back to basics, we've got hand hygiene and cough, sneeze etiquette, obviously. Just to remind you that our alcohol-based hand sanitizers, or ABHRs, need to be a certain alcohol to work, and they will kill most germs, and certainly it's been shown to kill surrogate viruses for COVID, other coronaviruses, etc. The other alcohol-free sanitizers, things like your compounds, if you don't want alcohol, they can reduce microbes, but they are less effective than alcohol. And I haven't seen, I can't speak to any particular products, obviously, in this presentation. So I just got to give tribute to New Zealand. So Susie Wilkes, who some of you will be aware from Auckland, and Toby Morris have done a series of illustrations and information on the, forgotten the name of the, it's like a blog thing. Anyway, and they're really visual and they're very good. And everyone asks, how long does it survive? And as of the latest evidence, you know, there's very few papers coming out about it, but what they say roughly is 4 hours on copper. So it depends what it is the bugs land on, and then about a day on cardboard, 2 to 3 days on plastic and steel, you know, if you don't clean it off. So it's not like a spore. It doesn't last forever, but we still need to do some cleaning. I would get you to look up this Toby Morris Society Viruses versus Everyone. It's a very good series of cartoons that's very, very informative. So if we look at our environmental cleaning products, so the TGA, which is our therapeutic goods people in Australia, with which I know many of you, and we did in New Zealand, try to follow their advice, because we have an agreement with them, although we don't have a partnership with them that I'm aware of, unless that's happened in the last couple of years. So on the 27th of March, they put out a statement, and then another one on the 28th. And they basically are expediting all claims from companies who are saying that their product will kill coronavirus. And so, because a lot of companies who make surface disinfectants, etc., really want to be able to give you the assurity that it's going to be useful for you. And, you know, we have to work very hard with our industrial partners in these times. So the TGA are trying to, expedite those claims. They also pointed out, it's a very good, you need to go and have a look. They pointed out the difference of how they consider disinfectants. So they look at hard surface disinfectants versus medical device cleaners and disinfectants, which is very different. So you just need to be careful that because something says it's a hard surface disinfectant, it won't necessarily have been approved by the TGA or listed by the TGA as being able to use on one of your medical devices. So what they're saying is if the claims that a product kills or is active against these things are specific claims, and they need listing prior to supply in Australia. So if you pick up a product and it claims that it's active against coronavirus, but it's not listed on the ARTG, which is the listing for the TGA, it wouldn't be allowed to be supplied in Australia for healthcare. In New Zealand, I think you could buy it, but just be aware that their claims may not be true, so you have to always be careful. What they have said is the surrogate viruses that you can use are human coronavirus, which is the 229E, which we see every winter. It's one of our winter viruses, and then a murine hepatitis virus. And if I just go on and explain why that is. So coronavirus isn't an enveloped virus. It has an outer membrane. So the point is, that outer layer is easily damaged by most environmental disinfectants. So it's much easier to kill than a non-enveloped virus, for example. And so most of our environmental disinfectants probably will kill it if you use the disinfectant according to the label instructions. So what the TGA has approved suitable for use, and these have to be products that are either registered or listed with them as hospital-grade disinfectants. They have said that detergent and or disinfectant pregnant wipes with those claims can be used for small items of patient care. They've also said greater or equal to 70% alcohol, quartine ammonia, quarts, and as we know, diluted household bleach at 100 parts per million of available chlorine is the standard one that we all know about. Obviously, well, not obviously, but you are probably aware that disinfectant wipes are also in short supply, and we have to, if you're not aware of that, I would would start thinking very early on how you may want to conserve your stock of wipes for things when you really want to use a wipe and you don't want to be needing to make up solutions of bleach, which are a really bad occupational hazard in some ways. We were probably going to have to do that. So if you've got a nice stock of wipes, I suspect they won't be that many around in another 2 months. So unless China comes back on board very quickly with manufacturing. Just in terms of environmental cleaning, this is not teaching you anything new. You know, one of the things is generally keep things clean anyway, declutter. Remember, your detergent is there to lift your dirt and soil. We have many products now that are combined detergent and disinfectant, including bleach products. So if you look at your bleach tablet or your bleach product, some of them will have a surfactant or some sort of detergent that helps clean as well as disinfect. And, you know, there's a lot of talk about regular basis, but cleaning surfaces, you know, at least once a day. Frequently touched surfaces such as handles and doorknobs. If it's in a hospital environment, if you've got your cleaners only going in once a day, I would be getting the nursing staff to clean those doorknobs, etc. At other times when they're going in the room, and especially after any aerosol generating procedures. So the bottom diagram is the things in our community that we see that might be contaminated. We all knew about the credit card terminals before. I don't, and you know, obviously the others are in a hospital setting. Most of us will know what our high touch areas are. So just to go back to some of the other basics about trying to prevent transmission. We have our social distancing, whether that's within a clinic situation. We all know we're supposed to be getting our patients to ring ahead. Our clinics will be cancelled mostly, all, you know, sending text messages out, all those sort of things. And so we're in lockdown now in New South Wales since Monday night. We're behind you guys, but we all know about our social distancing when we're out having a wee walk. And I get the bus, and I've gone from a crowded bus, and there's now only 3 of us on it, so we can easily social distance. And the bus drivers, the card swiper that's closest to him has been disabled, and the first 2 seats behind him or her has been disabled, so he doesn't have to, or she doesn't have to wear a mask all the time. This is your bubble. I know you probably are sick of it, but I love it. I mean, it's such a breath of fresh air for us in stuffy Australia sometimes, and it just, you know, it really is very visual. And yeah, you're probably all sick of the bubble, but I just thought I'd put it up there. Of course, the drive-through testing has taken off in some places. We're certainly doing it in Australia in a few places, as well as having pop-up swab clinics in quite a few places, and the one on the left was the Christchurch outside Hagley. Interesting, that's by GP appointment. I remember the CVACs in the pandemic influenza were not GP appointment at that point, and our pop-ins over here in New South Wales, they're also by GP appointment. Now, I know a colleague here, and she does some shift work on that, and she said they only had like 11 people because people weren't making appointments. They would have had far more. So they may change that sort of approach to using them, but it certainly cuts down on trying to manage a space and having people sitting around. It is a very good idea. Our certainly Australia's temperatures might be slightly nicer for managing this sort of thing at the moment. Isolation quarantine, for those of you who know me, my original research many years ago, my master's, was looking at the effect of isolation on patients for MRSA precautions. And, you know, we are quarantining people, very much so. And we're using primarily contact and droplet precautions. Patients in the room can't come out. They can't come out and go and get a cup of tea. They can't do anything like they might have under some contact precautions previously. And you have to remember their mental health. Like some of you might be going nutty already. Remember, these people are also very worried because they know that they're positive. So what you really should be doing is really thinking about their mental health. And one of the things that they did on our inpatient ward, just a little thing, is they made sure that the telephone number of the nurse's desk, it was printed and stuck on the inside of the door for all the patients, because most patients have got phones, mobile phones, so that they could at least, they didn't have to keep ringing the bell. They could ring through and just say, it just meant that the nurse didn't have to, if they rang the bell, they'd have to sort of come and knock on the door. And and some of our patients didn't do well. We had an elderly person who really found it incredibly difficult to be stuck in that room. So you always need to think about how they're managing and coping mentally when they're in hospital, especially. Okie doke, just going to have a quick water. I haven't got a sore throat and I'm not coughing. We're all getting gravelly throats, talking so much that, you want to be rushing off and getting swabbed. So what's our PPE? This is my area of that I like. So the PPE are standard PPE, and none of these items are new. And this is the amazing thing for us in the profession, is that suddenly we're having to do all this just in time, and this, checking of PPE and people wanting PPE education. And it's been an incredible eye-opener as to just how non-confident people are in using standard routine PPE that you use for standard and transmission-based precautions. Some people are fine, other people just really, we've done so much, like, we've done a lot of checking of PPE ensemble because we're using 4 pieces of PPE. And people just aren't used to using 4 pieces. I mean, my own research, I think there's like 5% of people ever use eye protection, and suddenly eye protection is everything now, along with masks. So people are really needing to upskill. And, you see them put the masks on back to front, you see them struggle, they take masks up and over their head, all sorts of sort of dangerous things that they have no idea, they are not aware of doing that. So it's your regular gowns, your surgical masks, some sort of protection for the eyes, and sometimes the mask and eye protection is together. As the visors ran out, we've had to go to reusable goggles, and what we are not promoting is a load of PPE that is not required. And I know some of you out there will disagree with me about footwear, but we are not promoting covering your shoes. We have never covered our shoes for flu. We've never considered the floor to be a risk to us. We don't crawl around on the floor. What we do say is, if you come to work, you need to be working in some sort of shoes that you can clean. And maybe the simplest thing is that you just leave your shoes outside the door when you go home, so that you're not walking into the house. But it is not something that we should be putting on lots and lots of overshoes. And there will be people, it's a big audience tonight, will disagree with us about that, but this is what is standard care promoting within the environments of New Zealand and Australia, where we do not have cities that such a high percentage of people have coronavirus, and where we've got hospitals absolutely overflowing with coronavirus, with COVID. This is a situation now, and we are certainly not promoting coveralls or booties or any sort of full face hoods or that sort of thing. That is really a level 2 high consequence infectious disease ensemble of PPE, similar to what you might consider for a viral hemorrhagic disease that is primarily spread through contact of blood and body fluids. Our disease is primarily spread through droplets, respiratory droplets, and some contact through the hands to our face. So we're not getting splash and contamination to our shoes in that respect. But the main thing is, no matter what PPE you use, it's about how you use it. And it's really all about using it safely. So one of the things is being familiar with the products. And if you have staff going in and have never used a visor before, they've never used eye protection, or even a P2 mask or a N95 mask, they need to be familiar with how to use it safely. So they will unfortunately have to get some training. And we've done hundreds and hundreds and hundreds of people, and we're now training the trainers so they can go into the wards, so all the educators, people coming in from outside agencies so they can take it back and train their staff, because it's not complicated PPE, but you do need to have the basic principles of what is safe. Alongside that, you need to have an understanding of how that COVID is being transmitted. So you need to explain why you're wearing a surgical mask, why we're wearing gloves and aprons, so that people are not getting, wound up about feet and wound up about lower legs and stuff that really is inconsequential to keeping them safe. The safe donning and doffing techniques. So some of you may or may not know that there's been a general shift in terms of doffing from the standard CDC doffing techniques that we've all taught for many years. With this new coronavirus coming out and the focus on eyes, especially keeping our eyes and face safe, a lot of people who have developed posters and doffing techniques are now taking their face protection, so their eyes and their visor off just prior to the mask. So the previous doffing sequence was your gloves off, your visor off, your gown off, and your mask off. So what we have and many other people have done is gone gloves, gown, eye protection, then mask. And that's just recognizing that we want to keep our eyes as safe as our face. So some of you may have already trained hundreds of people in the other way. I'm not saying that you just have to change all your training, but just be aware you will see stuff out there that is now changed from what we always were entrenched and did. It really helps to have posters or videos of you doing it. Some places are using virtual reality. Whatever you can get, the visual is always good. And I know we're super busy and it's really hard, but there's no point in training 800 people and then you go out and you're seeing them do it the wrong way. Somehow we need to find time, even if it's just once a day, to check one person on an inpatient ward or one person in your GP clinic or whatever, just to check that people are doing it the right way, that there's no Chinese whispers going through, especially if you're doing the train the trainer or a super user education model. So briefly, just want to talk about which masks, because this is quite a big thing. So surgical masks meet the AS 4381215, which that's the standard single-use face mask for use in healthcare, whereas our P2N95 particular respirator mask has to meet a different standard, which is more of an occupational health and safety industrial standard. And as I said before, the surgical mask, that's about droplet contamination, generally large particle droplets. They're attached to mucus, whether it's coughing or sneezing or whatever, and they fall mostly after coming out of the ground. They're so heavy they will fall, out of the mouth, they'll fall to the ground. Whereas true airborne particles will stay in the air for a very long time, and that's when we want to make sure we're not breathing them in. Now, I believe that COVID and coronavirus, when we do aerosolized generating procedures, they are not quite the same airborne route as, say, our multi-drug TB is, or something in the way of measles or chickenpox. I believe they are much smaller, obviously, than what droplets are, but in general, it's more about making sure that we don't just breathe them in, but they don't get in the sides. I've done a lot of P2 N95 fit checking, and not everybody gets a total 100% seal. If you look at my face, sometimes there's a bit of fogging, there's a little bit comes up here. That doesn't mean that they're unsafe. They will have eye protection, and you have to think about what it is you're actually doing at the time. So these are the differences. The P2 refers to the European standard, and the N95 which refers to the NIOSH standard for 95% filtration. So what about PAPRs? So PAPRs are positive pressure devices, and there's been a call for these coming out of some of the colleges, although ANZACs and that have said it's not necessary. So just to show you on the left, the left of my screen, is a half-face paper mask. So this is a quite a new invention in recent years by a company, and they have, you can't see, but that person who's wearing the goggles, the mask, got the stethoscope around the neck, probably not the best thing there. But anyway, at the back of their neck, you can't see, there's a little motor. So instead of like on the right, you've got the motor around the waist. This is just, it's a halo. It's produced by a company, and they have a paper mask that's attached to the motor, and the motor sits behind a bit like a halo. And that's their trademark name if you want to look it up. And it's really good. What it isn't designed for is Ebola type situation where you want to protect your face from a lot of blood splash. So on the right, you see a paper system whereby you've got a hood. We are definitely not promoting that. And the only real time that we suggest you might want a paper half mask like that person's using is if you're doing a very high risk intubation type situation, or you're going to be in the room for a very long time. So some of these are used outside of they're used in situations where airborne precautions are required, and a nurse might be in the room, and they're more comfortable for wearing for long periods of time than, say, a regular disposable mask. So they're not recommended widely for COVID, only in very select situations, and certainly not the one on the right. We are not going anywhere near a hood. So primarily we're talking at contact and droplet precautions. And this is just one of the posters that was developed at the hospital where I work when we still had face shields, and now we're using reusable eyewear. And so it's just an example of what that actually means. And I want to just show you this. This is like a stills video. Now, some of you, it'll just show you how to put on and off, and we're just going to run through it. It's only like a minute long. This is our inpatient ward, our COVID inpatient ward. This is my colleague Mary, Dr. Mary Wire. She's a nurse educator who did a PhD on patients' experience infection control. So we take our disposable in the room, but if it was reusable, we would do it outside of the room. I mean, this is not the way that you're maybe being taught. This is the principles. You've got to think about the principles. So that's just a quick stills of a video that we made. And remember, it's about safely removing your gloves safely, rolling your apron up in a nice ball safely from the inside out, taking your visor and your face shield or your mask off without touching the front ever. The same with the eye protection, always touch the side. Don't pull it up over the top of your head. We've seen a lot of doctors, doctors especially seem to have a habit of ripping their masks up and over their head. That's not very safe in today's world now. So we're trying to, reteach them to take it off like that. So those are the safe sort of principles. This is another poster that we developed for the airborne precautions. We also, of course, take our P2 mask off outside of the room. And there are a number of different masks now out there. And in our hospital, we no longer can get the mask that we would be used to. So we're having to train people in all sorts of different masks, both the soft duckbill and the harder shell-like. But it doesn't really matter for those airborne. They have to be put on correctly to be effective. And lots of people, in previous life may not have worn them correctly. So you just need to always make sure that they know how to put them on correctly. And then with the PT or N95, you have to do, you should always do a fit check, the seal. I'm not going to debate the pros and cons of fit testing. Certainly some states in Australia mandate fit testing. New South Wales doesn't. Most people here in New South Wales believe that, my understanding is most people, that fit checking is a very good method of ensuring that your fit is good before you walk into a room. We have said no to stubble and beards. So many men now have shaved their beards off in this hospital, especially among the anaesthetic team and the ICU team. And some of the respirators, you check them by doing a negative inhaling. Some of them it's a positive. And there are many videos out there now for the different types. So it doesn't matter whether you do fit testing or not, you should be teaching your staff if they have to wear a P2 mask to fit check it. Oh, sorry, wrong way. So just quickly talk about conserving PPE, because this is a big deal. So always control your supply. Don't ask your infection control nurses to control it in a big hospital. They've got enough work to do. Get somebody to control that, whether it's a product person or someone else allocated to that job. One point of distribution, locked up. So much stuff has been stolen, it's just unreal. So just make sure that your key stuff is locked up. Don't have a box of masks out for patients to, to help themselves to. One, they're putting dirty hands in the box, and also, you'll see 3 or 4 going out instead of one. Think about your use. Do you have to use it for a certain situation? And I know this is quite controversial at the moment, but think about other products you might be able to wear. Do you need to use full sleeve gowns for every interaction? And some people are using the reusable sort of theatre splash resistant gowns. We've gone, and some places have gone to extended use. I've touched on this briefly. You can use physical barriers to prevent some of having to conserve PPE, but you could use extended use in those cohorted areas. The most appropriate is masks or eye protection. For some groups of people who are doing drive-through or swab taking, they're keeping the gown on if there's no obvious contamination, and that would be appropriate as well in certain circumstances, and it has got to that stage in a lot of places. The masks must still be discarded if they become contaminated on the outside. You shouldn't walk around between different wards or go to your break and then come back. And you should obviously not wear them between positives and other patients. You can wear a mask for hours unless it becomes wet or damp, and it will still work, or it becomes too hard to breathe through, or it no longer keeps its shape. So, for example, a P2 mask. And always discard it after you've been in doing an aerosol generating procedure. Eye protection, again, is easily reused as long as you're looking after it and not contaminating yourself when you're cleaning it. We've gone with disinfecting it, but some places are just cleaning. It is best if you can give your staff their own glasses for that shift even, so they take responsibility for cleaning. And then, they know if it's clean or not. But touching outside of a dirty glasses and then touching another patient will still be a cross-infection, cross-contamination risk. So there's a lot of mixed messages out there about reprocessing masks, and this is of interest to many of us. So in the Netherlands, they have definitely come up with a way of sterilising disposable face masks, and they use dry and steam sterilisation. And there's also the FDA 2 days ago approved a company who could decontaminate N95 masks with hydrogen peroxide. There may be some problems with using Sterad because of the cellulose components. And 3M did put a statement out a few days saying that they do not, this may change, but at the time they do not recommend reprocessing masks. But this is a rapidly changing area, and I suspect we'll see more about this, especially in places like the States who are really, really struggling now with PPE. So there are other sources. This is an Australian company. This guy makes stuff for ships, boats, leisure boats. And he turned his hand to making, visors are very simple. And, you know, I know the problem is they're not quality controlled, but if you want to give some, it is very easy to make a visor, especially if someone, yeah, it's up to you. I'm just saying that these people are now shipping, will supply the healthcare sector with these face shields. This is going to be a very controversial one. So some of you may know the name of Elizabeth Beam. She is a Nebraska Ebola expert on PPE. She's a PhD nurse, Dr. Elizabeth Beam, and they have had to work out a way of reusing their P2 masks, and they do this whole quite complicated way of ticking off every 5 uses. Obviously, when they go to put the mask back on again, they use gloves. They have to do it in a very slow, measured way so they don't contaminate themselves. You don't keep it in plastic bags because the microbes multiply. You have to name your masks, not on the front. You don't write on the front. It's an excellent video. It's freely available if you really had to go down that route. I looked at it and I thought the risks to the staff at this stage were great, and we certainly wouldn't be looking at that at this point. But it is a safe way. If you followed her way of doing it, it's a very safe way of reusing a P2 mask for 5 times if you follow every step she does. And that's the killer, really. How can you walk away and know that every staff member is going to safely do what she does to prevent her cross-infection? So just again, taking swabs is not an AGP. This is your poster from the Ministry of Health, and it is about a surgical mask. And I just put a couple of pictures up to show you really have to get good cells to be able to diagnose a PCR swab. And so that means the tonsil area and right at the back. So not just at the front of the nose. So I'm nearly finished now. So other infection prevention control measures. Waste is always just normal clinical waste. There is no requirements for double bagging, and nowhere in the world have they asked, that I'm aware of, not in Australia or New Zealand anyway, that it goes down any special waste stream like Ebola had to. We just use the linen, transmission-based precautions, however you manage your linen. You shouldn't use a linen chute in case it all falls out, as it might create aerosols. And crockery's fine in dishwashing procedures. Some places have gone to disposable because it's easier. You don't need disposable from an infection prevention control perspective, but some places find it easier to manage. But I've seen quite a few different processes of being able to keep people safe who are collecting the dishes, etc. And just a couple of pictures. We set up a couple of clinics. The clinic's now moved twice, but we originally set up a swabbing clinic, and we had an inpatient isolation ward, which had a number of so this happened to be an empty ward. We were so lucky, and it was not set up. We had to try and beg and borrow a load of clinical equipment because it wasn't going to be a real clinical space. So that's how we've set up with posters and things. And everywhere will be different. And this was, when you get the slides, this is some of the resources I was referring to. So here was my other limerick. There was a young doctor who was keen, who loved to achieve and be seen. They were shown how to mask, but failed at this task, and now they have COVID-19. Thank you, everyone, and I'm sure that I will be taking some, just looking at the time, so it did go an hour, sorry, Catherine. So I can't take questions for 40 minutes like Ben. I might be able to manage questions for 15 or 20 minutes. Luckily, I don't have to choose those questions. Catherine's going to choose them for me.
Thank you, Ruth. That was fantastic. Yeah, the questions have been gently flowing in through your conversation. So at the moment, we've got about 17 questions lined up.
That's good.
So not too bad.
Good.
So to get started, we've got, I'm just trying to think here, get a question. How much aerosol is produced by coughing, not induced coughing?
So very little, and that's why we don't class it as an aerosol problem. So we don't have to wear a mask whereby those cough droplets stay suspended in the air for a very long time so that we will be breathing them in. Remember, every time you cough, you expel with with mucus, some sort of fluid, so they're generally heavy. There are a few aerosols, but it's not been shown, coughing itself, to require the use of a P2 or an N95 mask. You still should be wearing a mask, and that would be a surgical mask. And remember, we can still fit our surgical mask better than we might have done. You pull it down under your chin, you make sure that the top is bent around, so you have got a very good protection of your nose and mouth at that point. And remember, for COVID, we are also protecting our eyes. And intraocular transmission of RSV and other respiratory viruses has been demonstrated in the past, and we know that poor doctor in China who alerted us to this, he was an ophthalmologist, had done the surgery without eye protection, so he may have contracted it through the eyes.
Okay, and then we've got in the Ministry of Health poster for community care PPE, is there a reason that a gown has to be worn during medication administration?
I don't know. I'm not sure. Sorry, I won't be able to. Is this for a COVID patient? So there has.
I was wondering.
Yeah.
Maybe if it's.
Yeah. Sorry. So I'll just take away my limerick. So I haven't looked at all the posters. I mean, we talk about contact and droplet. There's certainly, I know that in some of the less at-risk areas like community care, aged residential care, now they are starting to conserve gowns by, say, carers going in to look at, go into an elderly resident. They're not having to wear gowns unless they think there's going to be a splash or a risk. Yeah. So the medication may come under that eventually. I wouldn't like to say.
And they've got, hi Ruth, I am a community midwife in Queenstown. During our clinic, seeing multiple well women on the same bed throughout the day. Would you suggest us to be changing the sheets and pillowcase after each woman?
So I would say, what do you normally do? I mean, I'm assuming you mean with their clothes, that like you see them with their clothes. But I mean, if you're doing any exam where there's likely to be, I'm not sure what you're doing on the bed. If you're doing a sort of exam and you're touching them, they're touching their skin and touching round under their tummy, what have you, and then you're touching that bed, you should be cleaning or doing something to prevent transmission from a shared couch when you're doing examinations. I mean, a chair someone's sitting in is very different, but in the era of COVID, we don't have huge amount of community transmission, very little community transmission at the moment. So what I'm advising is nothing to do with COVID. This is about standard precautions and general cleanliness of your environment between your clients. And only and you can make that risk assessment. If someone's lying on your couch and you're examining them, what is the risk to the next person?
Yeah. And then we've got, while transferring in ambulances, where they're in limited spaces and are there for over 15 minutes, should we wear masks during this time, as we're inside the social space for the duration of the time?
So this is so read the first part, when transferring.
So if they're transferring someone in an ambulance, they're in an enclosed space, and obviously transfers are often for longer than 15 minutes. Should they be wearing masks during that time? And then the next part of that is, if they've got no signs, they're being advised they don't need to wear PPE above gloves.
So at this point, we're not, so if this is a suspected COVID, that's different. But this is just regular patients and transfers. If they've got no symptoms, no, the recommendations generally are that you shouldn't be treating everybody at the moment as if they're possible COVID. We really are not at that spot yet. So there are recommendations and guidelines for paramedics and for ambulance crew, absolutely, for management of suspected or confirmed transfers of COVID patients. But for routine, care, no, at this stage, we're not at the stage where we should be putting a mask on for every patient because they're going to be in the ambulance for 30 minutes.
Yeah. And then we've got, does aerosol mean dental procedures more at risk?
Yes, definitely. So your line, your water lines, all those drills, high-speed drills. So dentists have all been told now that in Australia, that they're not allowed to do, they've to cut down all their dental. So once it gets to the point where you'll be told that, and your dental people will be told that, you will not be able to have routine dental care, because absolutely dental procedures are high risk. A lot of them, exams, anything that includes drills or suctioning or spraying that water around, that creates aerosols. That's up to your experts from the Dental Council to decide. Are dentists at that point now where they need to start, looking at what they're not going to do?
We've got one saying about eye protection. Can you wear prescription glasses? Are these acceptable forms of eye protection, or should a shield be worn over them?
So prescription glasses have never been an acceptable form of eye protection, except some people have occasionally had special protective eyewear made with prescriptive glass in them. I've come across that with a young intern once. No, and it is a problem for some people. You can get eye protective goggles. Well, when I say goggles, they are eye protection, not the big thick goggles that will go over your eyes. You can get half eye protective, visor sort of face shields that go over you. You can't rely on your glasses. There's no side protection, and they generally are not considered eye protection.
And then they've got somebody, I'm not quite sure who this is, said, are goggles, tight-fitting ones, a must, or are safety goggles suitable?
So this whole thing about eyewear is quite confusing, because people use the word goggles, and so it causes a lot of confusion, because I think of goggles as those sort of tight, like goggles that you might use, you know what I mean, the ones you sort of saw in Ebola out in Africa that the MSF workers, etc., had to wear, whereas the most common form of protective eyewear are like the laboratory protective eyeglasses, or the ones you can buy in Bunnings for industry, and those are perfectly satisfactory. You don't need the tight-fitting goggles. However, there are some individuals out there who believe that nothing is safe unless they are tight-fitting across their eyes. We certainly don't, that there's nothing to say that you have to have those, and they actually, I don't know if some of you saw some pictures, they can cause, in Italy, bruising and stuff around your eyes.
And then someone has asked as well, it's just quite good at this moment because we're doing flu vaccines, about what they should be wearing for doing flu vaccines.
I can't remember what your guidelines are. I mean, at the moment, I'm not sure. I will have to defer you to go to your New Zealand Ministry site, because I'm pretty sure I saw something somewhere about vaccinations in one of those posters, and they may have done something special, since that we're now getting into the flu vac season, and are we mixing with COVID patients as well? Yeah, I'm sorry, I'm not sure about that. I know what we normally would do, but yeah.
And another one is, anything different for helicopter transfers?
So the whole thing about the transfers of COVID in aircraft, I've been involved at slightly looking at that. It makes a big difference, and I'm not a chopper expert. It makes a big difference as to so there's the two things. There's the air handling. I suspect this question is around the air handling. I would imagine the pressures and where the pilot sits. So one of the problems with transfers by air is, can you close off where the pilot sits, even if that's by a temporary sort of physical curtain? So transferring per person, you minimize that risk to the pilot by having some sort of a physical barrier between them and the person in the aircraft. If it's a fixed wing or something, you have if there's two different airflows, you change that for the pilot. You can put the mask on the patient if you can. If they're on nasal prongs, you put a mask over the nasal prongs while they're breathing through the nasal prongs, or a surgical mask over a mask. But I don't know the aerodynamics of a helicopter to advise whether what else. And we certainly know that people sitting in with the patient also has to wear masks. But the big question that came up previously when we were looking at this was about what happens with a pilot. Do they have to sit with a mask on all the time? I think it depends on how the air flows and the barriers.
Thank you. And this is quite an interesting one. Can I soak my grocery bought baby wipes with Genola to convert them into disinfecting wipes?
I would
as
say
an answer
no.
to the shortage.
I would say absolutely no. I mean, you never can mix disinfectants and chemicals. Remember, it doesn't matter whether it's baby wipes or whatever, they're still got chemicals in them. And Genola, I don't know why you just don't go to the op shop and buy a few curtains and cut them all up and you know, then put them through your, are you talking about in your house? I mean, you certainly...
I have more information on that. And so then we have a large stash of old N95 masks, the duckbill ones with perished straps. If we sew or attach new straps, will they be okay? I think they're from 2009.
Yeah, I mean, the point is, I don't know that you can guarantee the filtration of the actual mask if they're expired. I looked into the expiry of masks, and they generally have a 5-year shelf life, and that is over 11 years. That's 11 years ago. I wouldn't want to trust them as a P2 mask. They may well be okay as a surgical mask, but I wouldn't, you know, technically you'd want, I mean, they say you have a lot, you know, it's possible you might be able to get them technically tested from a penetration perspective for surgical splash. I wouldn't like to say they'd be okay as a N95. Not at all. I don't know. They might be, but I without getting them properly tested, I wouldn't be recommending it.
I don't know. How would you feel, Ruth, if there was a mobile health were to maybe just try and scale down some of the rest of the questions for you to answer at leisure later? Do you want to keep going? I'm just thinking that we've got another 25 questions.
No.
Yeah. Plus there's another lot coming on the web chat as well.
Well, how many questions did I actually answer in the end?
You've probably answered about 14 or 15, I would say.
All right, well, I'm going to answer 2 more, and then we're going to finish. And I'm quite happy for Mobile Health to send out a Q&A with the when they upload the slides onto the website. I can do that over the weekend. I can answer. I can't do it probably in the next couple of days, but I can certainly do it over the weekend.
Thank you. So can you please give a comment on homemade masks? Because of the shortage of masks. So a lot of patients are doing all sorts of homemade varieties off the internet.
All right. So for patients, like so I mean, for healthcare workers, it's very dangerous because you haven't got that quality control. There was Raina McIntyre is an expert in the field of this sort of thing in New South Wales, and she did a control trial in Southeast Asia. You're looking at cotton masks and other types of masks, and the cotton masks, especially material masks and paper masks, are really not very good at all at protecting for respiratory viruses. However, I have seen that the World Health Organization, I think, or CDC, someone has said that, you know, that we may have to get, people may have to get inventive about protecting their face. And I've seen people with scarves and things, you know, at the end of the day, if it's thick enough, you won't get splash into your face. It's just if that's something you want. But you got a question, at what point would they want to be using these masks? You know, how much, you know, like what, you know, yeah. And so here's your last one then. How soon can we use a room that was previously occupied by a positive COVID patient? Depends what happened in that room. If it was aerosolized generating procedure, so it became more airborne, you would have to look at the air changes, and that can range anywhere between 20 minutes to 15, depending on, or longer, even up to an hour. If you've only got something like 5 air changes an hour, for that to be safe, you'd need to wear PPE if you were going into that room to clean it, for example. On the other hand, if it's just a regular patient and they've been you know, haven't been wearing a mask but have been in there, you know, I always think if they've come out, by the time you've done the paperwork, you can go back in there safely. Okay,
and there's like bucket loads of thank yous coming in, Ruth. A lot of people are very appreciative. They find it clear to understand, feel like they got some learnt a lot, some good refreshers. Fantastic. But yeah, just rolling in with all the thank yous for giving up your time this evening and helping everyone to get a bit of more understanding around what we're doing. So yeah, huge thank you to you.
Oh, well, my pleasure. And it's been a pleasure talking to New Zealand. I just wish I was home now. I'd love to be home and maybe be home at the end of the year, if I can get in.
Yeah, with your 14 days, of course.
Yeah, absolutely. Well, thanks everyone, and everyone keep safe and just keep doing the right thing and avoid touching your eyes, nose and mouth.